surprisingly, the testing rates for patients with these kinds of cancers is unfortunately quite low. In fact, data has shown us that only about 50% of patients will get HER2 testing, only about 50% will get MSI or PD-L1 testing. And really, the use of a multi-gene panel or multi-testing platform is really at best about 60% in the academic setting and as low as roughly 30% in the community and private setting. So how do we encourage treatment? Well, really, it needs to become part of our DNA, no pun intended. It needs to become part of our overall perspective of how we're going about treating these patients. First of all, we probably should think about testing from the outset. Now, in some cases, we will actually want to get those test results back before we even initiate testing, so testing prior to first-line therapy. And that's certainly true, as we talked about in the HER2-targeted population, where the addition of upfront targeted therapy in HER2-amplified cancers can actually improve survival. But it's not always reasonable to get those test results back in a timely manner. So while the studies were not designed this way, and I want to emphasize that, it certainly wouldn't be unreasonable to initiate testing, concurrently initiate chemotherapy, and then if the testing shows that, for example, there's a HER2 amplification, to then add HER2 targeted therapies such as trastuzumab to the chemotherapy cocktail. But for those patients who we don't necessarily need to incorporate the targeted therapy to the upfront therapy, well, then we should also think about starting testing as soon as we can, just so we don't forget. What we don't want to have happen is that a patient who's receiving their third line of therapy and they're really running out of options to then think, oh, I should have done that biomarker testing. So I like to do the biomarker testing really concurrently with starting first-line therapy so that at least I have those biomarker test results in my back pocket as the patient needs to move on to maintenance therapy, as in the case of olaparib for germline BRCA1 or BRCA2 mutated pancreatic cancer, or for very active second and third line therapies, such as FGFR fusion positive cholangiocarcinomas, FGFR fusion positive gastric and gastroesophageal cancers, or as we've discussed previously, HER2 amplified gastric and gastroesophageal cancers with the use of TDXT. So I think that that's the paradigm to try and be able to incorporate this biomarker testing as quickly as possible.